So we're back. We took a little bit of a break from teaching just because I had a lot of funny ideas, but we're back and we're going to continue with magnesium. So have you ever been in a department store and you see like a little kid that's acting out or screaming and hollering and his mom has him by the hand and she's like pulling him? She's like, stop it, you're going to get a spanking. Come on, you're embarrassing me. Okay? That's magnesium. Magnesium keeps everything in line. The nerves and the muscles, they all want to go crazy because they have all this influx of information and stimulus from like acetylcholine and other neurotransmitters. So they want to go crazy. And magnesium like, stop it, boy. I'll give you a backhand. Stop it. That's magnesium. But how does magnesium do that? Well, magnesium inhibits acetylcholine, which is a neurotransmitter. So if the neurotransmitters can't go across the synaptic cleft, then they can't transmit information. Decrease in levels of transmitting information doesn't tell nerves and muscles to fire, so everything remains chill. That's from magnesium. Mag does a ton of other things. It has to do with DNA synthesis, protein synthesis, coagulation cascade, regulating calcium in and out of the cells. It does a ton of stuff. But for the majority, you're gonna know the things that you're gonna know about magnesium is gonna be that it chills things out. So how does our body regulate it? Well, intake. Remember when we said in my very first video, I think it was 18 videos ago, that when it comes to electrolytes, it's either too much in, too much out, not enough out. So intake, GI-wise, is where you're going to get your mag. And it's going to come out through your urinary tract. Another thing is acidosis. Acidosis is going to make the intracellular mag come out and go into the extracellular space or the bloodstream. So if you've noticed the pattern here, acidosis and alkalosis play a major role in electrolytes in general. We talked about what it did with calcium. We talked about what it did with mag just a little bit right here, and then potassium's the big one when it comes to acidosis and alkalosis. We'll talk about that later. Just know that if your patient is acidotic severely or alkalytic severely, their electrolytes are going to be off and you're going to need to check them. All right, so let's get into it. Let's talk about hypomagnesium. What are some causes of hypomagnesium? So you get magnesium through your diet. So if your diet is poor, you have malnutrition or starvation, your mag levels are going to drop. So it's important to make sure that you're getting adequate nutrition. You're alcoholics. Alcoholics are notorious for having low mag. Not all alcoholics have it, but the majority of them do. If somebody comes in drunk, odds are that their magnesium level is going to be low. NG suctioning. If you're NG suctioning somebody and you're pulling all the nutrients out of them because they have an obstruction or something, their magnesium levels can start to drop because we're pulling all the nutrients out, as well as TPN. Now TPN, it can occur, but usually your pharmacist or your dietitian or your renal doctor, they're going to titrate the TPN to that specific patient, so their mag levels will be measured according to them. Now the parathyroid hormone is still going to play a role here. It does affect magnesium as well. You could call it kind of mama parathyroid hormone stepchild, because calcium and magnesium have a direct relationship. So the things that affect calcium will also affect magnesium. Now we said that the way magnesium exits the body is through the urinary tract. So if you're taking medications that increase your urinary output, magnesium is going to go with it. Before, with calcium, we also talked about blood transfusions. Blood transfusions do not contain magnesium. So the more blood transfusions in a rapid succession you give your patient, that will lower your patient's magnesium levels. So you're going to have to check these levels just like you had to check calcium in our previous videos. And when we talk about hypomagnesium, we mean that the levels of magnesium in your bloodstream are low. But anything that would cause magnesium to enter into the cells and remove it from the bloodstream or the extracellular fluid would be causing hypomagnesium. One of these is rapid infusion of glucose, or TPN, that's high in glucose, with insulin. This glucose will shift magnesium into the cells, lowering the levels of magnesium in your bloodstream. Another one is alkalosis. If acidosis makes it come from the ICF to the ECF, then alkalosis does the reverse. It's going to make it go back into the cells. So if your patient is alkalytic, your magnesium levels will drop. So if magnesium is that mom or that grandma in the department store keeping things in line and laying backhands out, when she's gone, when she's hypomagnesium, things go wild. One of which being your heart. And there's a specific rhythm that only occurs when magnesium is super low. It is called torsades de pointes. okay, or torsades de pointes, or however you want to pronounce it. That is that ventricular fib with that twisting rhythm of multifocal large to small and large to small. And that immediately should tell you that your magnesium levels are too low, dangerously low. Well, obviously dangerous because you're in ventricular fib. But you need to administer rapidly magnesium to this patient along with CPR and everything else that goes. Now, remember, everything's excited, so your muscles are going to start cramping. Muscle cramping and tightening, okay, due to low magnesium. They're going crazy right now. They're running through the aisles. They're pulling clothes off the hangers. They're going nuts in the department store because Mama Magnesium's not there to lay the smackdown. How are you going to treat it? How are you going to treat your hypomagnesium patient to get rid of these symptoms? Typically, we're going to give IV magnesium, but we're not going to exceed 15 milligrams per minute as a typical rule. And that's really it for hypomagnesium, man. It's not as in-depth as calcium was. There's a lot that it partakes in. It's an important electrolyte, but the main risks are going to be your cardiac and your muscular risks. So once you identify it, you're able to treat it with IV magnesium, you're good to go. Let's move on to hypermagnesium.